We now can hear from another specialist taking another part of surgical practice. We have Dr. Ravindran. I'm very glad to be able to introduce Ravindran, who is the founder of Aravind Eye Care System, which really aims to achieve the very same thing of high volume, low cost, high quality eye care in India. Ravindran, thank you very much.
Good evening. At the outset, I would like to thank the organizers for this opportunity to talk about Aravind Eye Care System that has grown over the last 3 decades to provide eye care to millions of people. The Aravind Eye Hospital, it was earlier in the year, started in the year 1976 as an eye clinic with just 11 beds. Today has grown. And today, it has grown into a system where we have about 5 tertiary eye care centers. In addition to providing clinical care, it also provides teaching and training and takes care of research and sees anywhere between 1,000 to 2,000 patients. And we have 5 secondary eye hospitals in the semi-urban areas, which provide mainly cataract surgery and also facilitate specialty diagnosis and referral to the major hospitals. And we have about 6 outpatient clinics, which sees anywhere between 100 to 150 patients, and about 41 primary eye care centers, we call it as vision centers, across the state of Tamil Nadu and Pondicherry, which are situated in the southern part of India. And if you look, the blindness is one form of human suffering. It is just beyond disability in the sense it takes away the livelihood of the person, their status in the community. And of the 40 million people who are blind worldwide, about 12 million of them are in India, and a significant number of them are children. The irony of that is, most of them, 80% of them, need not remain blind. A simple cataract surgery that can be done about in 10 to 12 minutes can restore the sight in about 7.5 million people. And a pair of spectacles, you heard about it in the morning session, about how the need for glasses to restore vision. It can make about 2.4 million people see. And however, there are several challenges which are faced by this population. So they live in a very difficult living conditions. Their literacy level is very poor. Their health awareness level is also very poor. Their understanding that a cure for their problem exists is very, very low. And they all live on a daily wages. Every day they need to go for the work. Only then they'll be able to make enough money to take care of their daily needs. And with this low affordability, they face several challenges in the day-to-day life. So it is in this background, Dr. G. Venkatasamy, he is the founder of the organization. He started the eye hospital, the eye clinic in the year 1976, after his retirement from the government service. So he worked from 1951-52 to 76 in the government service, where he was also involved in the community work. After he retired, he strongly felt that these problems, the healthcare problems, cannot be addressed by the government alone. It has to be supplemented by the efforts of individuals from the private health sector or from the non-governmental organizations. It is with that aim he started this Aravind Eye Hospital. And however, he faced several challenges, being without resources what was available in the government. He was able to bring together some of the family members who are ophthalmologists to give up their job and join his team. And he did his best to create an access for the patient and make the eye care affordable for them, even when the resources are very low. And he also ensured that the quality remains very high. Without a good quality care, we will never be able to bring the patients into the system. So one of the things he did in the initial years is to create access by having rural eye camps. So here he involved the community organizations like Rotary clubs, Lions clubs, religious organizations, schools to conduct these camps in the rural areas. Where the community organization took care of publicizing the event to the public, they arranged the local facilities for the screening and took care of the hospitality of the patients as well as the other things. Here is a camp that is being done. And you can see the community volunteers take care of registration, they take care of the patient flow. They also help the doctors and the nurses in seeing the patients. So we have all the elements of an eye care that are provided in the hospital, like we have nurses take care of the vision. We have a preliminary examination done by the doctors who see the patients and take their complaints and order for the necessary investigations. We have mobile cubicles that can be used for doing the refraction, and we check the intraocular pressure, and the final examination is done by a doctor. Wherever there needs a dilated fundus examination is also done. The patients who are selected for surgery are transported to the base hospital on the very same day. The food and the transportation and the surgery is provided at free of cost for all these patients. They reach the hospital. In the hospital, all the tests that needs to be done for a surgery are all taken care, including the calculation of the IOL power, checking the blood sugar, wherever we need to do an ECG. And the next day morning, they all undergo surgery. They typically stay for 2 days, depending upon the distance. And after 2 days, they all go back home. And the most important thing also is to take care of their post-operative visits after a month, after 4 weeks. Last year, we conducted about 2,800 of such camps. Not only these we call it as a comprehensive camp. We also do a school screening camps, industrial camps, and also camps just to provide the glasses. And this approach may be very effective, may seem very impressive in creating access for the people in the rural areas. However, when we did a study supported by the London School of Hygiene and Tropical Medicine, we found that only 7% of the people in that village actually utilized the services. So this led us to think, how do we create a permanent access for the patients? That is when we came up with the primary eye care center concept, which covers a population in the rural area of 50,000. It may be located in a village or a small town which has got about 8,000 or 9,000 population. But in the surrounding areas also, it covers up to a population of 50,000. And it is staffed by only technicians, because having a doctor there on a permanent basis is not cost effective. However, the challenges were providing a comprehensive eye examination and giving the prescription for the patients for the treatment. So we came up with a facility where the technician will have access to a good equipments or whatever that is available in a doctor's ophthalmologist chamber in a hospital, like a slit lamp. And once she does the examination, she had a simple electronic medical record system where all the data were incorporated. If there is a need for taking a photograph, the photographs were taken and were embedded into the EMR. And she connected, the technician connects with the base hospital. Each of our 5 tertiary care hospitals take care of anywhere between 5 to 10 centers. So through the telemedicine video conferencing facility, the ophthalmologist in the base hospital is able to see the medical record, see the pictures, able to talk to the patient, and also the technicians, and provide a prescription. And this is a simple video. Here you can see the registration being done by one of the technicians, the refraction, checking of the intraocular pressure, if necessary taking a photograph. All that is done by another technician who have done a diploma in optometry. And we have found ways how to take the pictures of the fundus. Once all that is done, and it's the ophthalmologist, there is a cube. The ophthalmologist will select the patient and will talk to the patient and the technician. And he is able to send an e-prescription, and which is given to the patient. If the patient needs a glasses, and they are provided right there at that point, because the other technician who mans the center is able to fix the glasses and give it to them. All this happens within a time of about 3 to 4 hours time. And today we have about 41 centers, which covers about 3 million population. In the last year, we had about 270,000 patient visits, consultations, which means we do about 900 consultations a day. We give about 70 to 80 spectacles, and about 90 to 100 patients are referred to the hospital, which means almost 90% of the patients are taken care in the village. And we are also able to, we have seen that we are able to reach 75% of the people who need eye care in that given population within a period of 2 years. With any other way of reach, we won't be able to give this kind of a reach for a given population. So what we have done to create access is to create systems or services for the non-customers, for the people who are not coming to the healthcare facility. That is what we have done through this vision centers and the community, through the community-based outreach camps. And all these activities in the community, we have strongly involved the local community to take ownership. And we have a very structured monitoring that happens every week on a Monday. And when the patients come to the hospital, it's an open access and there is no appointment. Today, across all our hospitals, we see anywhere between 10,000 to 12,000 patients in all our facilities. And all that happens without any appointment. And at the same time, creating the access is very important. At the same time, making it affordable is also very important. It has to be affordable to the patient as well as to the provider who has got very limited resources in a country like India. And there is a way to define the cost. Even when you provide all this care free, even when the patient comes to the hospital, we have a separate free hospital where the patient can walk in, have a consultation at free of cost, have the surgery at a very steeply subsidized thing. But still the patient, especially from the rural areas who belong to the low socioeconomic group, always look at the last wages as because of the time investment, because of whatever they lose on wages on the particular day. They look at the travel cost. They also always accompanied by another person to take them to the hospital. So this patient also need to bear the cost of the travel cost for that patient, food for that particular day. And in addition, if you are going to ask the patients to come on several days to complete whatever care you want to give, it is going to become very, very expensive. So even if you are going to provide everything free, these patients may not turn up. So we need to be very sensitive about that. Just for an example, if you look at the cost of a spectacle, it may cost about 3 to 4 pounds. But if a patient goes, and typically when he goes to an ophthalmologist, he goes to the doctor, gets a prescription, go to a shop, orders, maybe they are asked to come on some other day. They go the next day to get the glasses, and they also have to go back to the ophthalmologist to see whether the glasses are all correct. So this process involves another additional expense of maybe like 3 to 4 pounds. As a result, even though the cost of the whole care becomes very expensive. So in all our eye camps, the 2,800 eye camps where we also provide the facilities for dispensing the glasses at site. So logistically, it's a difficult thing we need to carry to provide about 100 glasses or 150 glasses. We need to have at least about 1,000 or 1,200 different pairs, which all have to be readily available at the time. So all this happens within 2 or 3 hours in each of these camps, and it makes the whole experience complete for the patient. So the other processes we try to complete all investigations and treatment for the patient in a single visit. If the patient comes, he needs a surgery, he is admitted on the very same day and operated on the next day. There is no appointment system for any of the procedures, either it's a laser or for any kind of a complicated, complex surgeries. There are no waiting lists. We also try to eliminate all the unnecessary tests or maybe processes if we feel that it is not very scientifically backed up. There are no good evidence to say that this process is very important or this test is important, even though it may be against the conventional protocols being followed by others in the profession. We also look at the length of stay. We look at the reasons for the patient staying longer for the surgery or not getting discharged post-operatively. All this data are looked at on a monthly basis, and we try to find some solutions for that. So we feel that the cost of access, the lost wages and incidental expenses can be very significant if you are not really sensitive to the needs of the patients who belong to the lower socioeconomic group. This also applicable to any patient belonging to any kind of a social segment. At the same time, we also need to define the cost for the provider. The important resource in any hospital are the physicians and the equipments. We have to make sure that these resources are not wasted or not used inappropriately. So for that, we have delegated some of the work that can be done by the paramedical workers. So any type of measurement, whether it may be taking a vision or a refraction or doing an ultrasonography, or maybe any complex things like a OCT. We have any kind of a measurement, we have given it to a paramedical staff who can do a much better job. If I ask a doctor to do about 40 or 50 ultrasounds a day, they will not definitely like to do that. Instead, if I ask them to do about maybe 40 surgeries, that may be a challenge for the ophthalmologist, not doing a particular test repeatedly on the same day. And this is an example for you. If you look at a scenario A, where a surgeon has got one operating table with one nurse and one set of instruments, he may probably be able to do one surgery in an hour. If the same surgeon is given additional resources in the form of 2 tables, 2 nurses, and adequate sets of instruments that can be autoclaved using a flash autoclaving, that surgeon may be able to perform more than about 6 or 8 surgeries. And this is a model we use in all our hospitals. If you see, as this doctor is operating, a patient is being prepared on the next table. So as he finishes the surgery, he only swings the microscope. Now we have adjusted the table in such a way that he'll be able to exactly start the surgery once he finishes it. So the time lost between the surgeries is very, very minimum. So all this is possible only because of the manpower we have. We have, every year we take anywhere between 400 to 500 village high school girls. They are given a job-specific training. We have identified 9 areas of training where they are trained only for that particular purpose, and they are very supportive. Because of their involvement, their commitment, their attitude, we are able to make the surgeons really productive. At the same time, it also positively impacts the life of these girls to a great extent, and as a result, without any effort to advertise in the media, we are able to get the nurses year after year without any difficulty. And all this processes, this is an example I've told you, really enables a higher productivity of the surgeons and each surgeon performs anywhere between 1,500 to 2,000 surgeries. And last year, we handled through these hospitals, through the vision centers and the eye camps, we saw close to about 3.1 million outpatients, and we performed about 370,000 surgical procedures. This is roughly equivalent to about 65% of the work done by NHS in UK. And 50% of these patients were treated either free or at steeply subsidized charges. And when you have this kind of a volume, and when you have patients from the rural areas, it becomes very important that you ensure quality. It's very, very important. We have clear protocols for all the clinical areas for safety, identification of the patients. We have an incident reporting system through our intranet where any staff can have open access and can report. And we have clear guidelines for advising surgeries, for the follow-up, and also some of the common diseases like glaucoma, diabetic retinopathy, which needs repeat visits. We've got a very clear protocols. We also pay a lot of attention to training of our residents and fellows. Our concept, even though the training period is 3 years, we try to make sure that they become good surgeons by the end of 12 months. So they put a lot of time in learning in the wet lab surgery, and they have a dedicated time to learn during the 6th or 7th month. And during the 7th or 8th month, we provide opportunities for them to operate every day under the supervision of a doctor. As a result, the doctors become really good, and they become very productive doctors by the end of 2 years, where they become part of the team. And we also have one of the largest registry in the world, the cataract surgeries. Last year, we have done about 270,000 cataract surgeries. All the data is captured here, which you can see here, and which also gives all the complications, post-operative complication, visual outcomes, and the date of the infection. It also has got a benchmarking. The doctors, they can, among their peers, they'll be able to benchmark them in terms of volume and their seniority. Also, we'll be able to do that. It also gives a trend analysis for the last 6 months regarding their visual outcome complications. And at the same time, ensuring compliance with the patients is very important, especially those from the rural areas. we need to make sure that, they follow all the instructions we give them and report for the follow-up examination after 1 month. They are also told very clearly about the medications they need to use. And for conditions like glaucoma and diabetic retinopathy who need to come on a regular basis, if they don't turn up, we also send them reminders through the SMS. And the most important thing, being a community-based hospital, a large volume hospital, one thing we really focus right from the beginning is to sensitize all our staff that we need to be compassionate to all our patients and we need to preserve their dignity. And this compassionate approach and treating the people with respect and dignity has really built the trust about Aravind Eye Care System in the communities we serve. And without any effort, without any effort or publicity in the media or in the press, we are able to get maybe about 7 to 8% growth every year. And as you can see here, we have grown, and as you can see, maybe about 50 to 60% of the patients receive free care year on year. And if you look at the fee structure, the consulting fee for the poor patients who is free, and the paying patients pay anywhere between about $1 to about £1. And for the cataract surgery, for those who come through the camps, it's free. And if those who come directly to the hospital pay a very nominal amount of about $14, $15. The paying patients who get a surgery similar to what is available in the West, they pay between $200 to $400 depending upon the type of implants they require. And where they go, where they they want to avail the services free or they have to pay, it's all self-selected by the patient. These are all two separate hospitals, entry is there, and the patient can choose to go where they want to go. We don't decide, we don't ask for any proof that they are poor or they are economically of a weaker section. And if you look at this is our the income chart. This is the income and this is the expenses. As you can see that we have a reasonable, very decent surplus year on year, which we use for the expansion and for taking care of other needs. Last year, we were able to save about $10 million, which is about 34% surplus. And in spite of the fact that only about 45% of the patients were paying patients in that group. And if we need to attain our goal of eliminating needless blindness, we alone may not be able to do that. So we have to give away our competitive edge. So we have been very interactively working with several other eye hospitals so that we are able to achieve this goal. Today, we work with more than about 280 eye hospitals in India as well as elsewhere in the world. So we have a 3-year hand-holding process with all this non-governmental organization, voluntary eye hospital, charity eye hospitals. Most of them are in India, but several of them are in Africa, South America, and also in Southeast Asia. These hospitals, we were able to, with all this, the training process or transferring all these best practices, today they are doing about 800,000 surgeries more than what they used to do earlier. And we also realize the need for, if we really have to make this eye care affordable for all the people in India or anywhere else in the developing country, we also need to make these supplies cost effective. The supplies, what comes from the West is not really affordable for the patients. So we established an organization called Aurolab, which is a manufacturing facility. And it started with making intraocular lenses. But today they make sutures, pharmaceuticals, and other surgical supplies which are needed for eye care surgery. When in the pharmaceutical, we really look at only the orphan drugs which are not really paid attention by other pharma companies because of the low volume and the price factor, it's not being produced. All those things are produced by Aravind for the sake of the patients. And today, these products are used in over 120 countries, and we have about 7% of the global market. This has significantly brought down the cost of eye care in many of the developing countries. To conclude, the healthcare, what is most required is the compassion and we need to have the basic values within the system. So if we have these two, we'll develop the right perspectives, we'll develop innovations, how to deliver the care, how to make it affordable for the patients. All that needs very strong leadership, and we were fortunate enough to have a very strong leadership team earlier on. I joined as a resident in that hospital in the year 1981-82 after 6 years of starting. Today, I've had the opportunity to head 5 of the hospitals which were started later, and today I took up the position of the chairman about 2 years back. Thank you.
Dr. Ravindran, thank you so much for that inspiring talk. I'm going to suggest that we leave now on to the welcome reception, and if people want to ask any specific questions of Dr. Ravindran, you're welcome to come and do so at the front of the hall. Thank you very much indeed for a marvellous talk.